welcome back, everyone. I'm Chad Higgins. I'm the Associate Vice Chancellor for Extension Engagement here at the MU campus in Columbia. And this morning's panelists helped us explore the many challenges we have in addressing the effects of Missouri's opioid crisis that have been particularly crippling in our rural parts of the state. They have also showed us what is possible if we work together as a village and come together across all expertise areas to find solutions. This afternoon, we will explore in greater depth workable health strategies for rural Missouri, the kind of strategies that can make a positive impact on areas such as the opioid crises. To help guide us through this conversation, I'd like to introduce Garrett Hawkins. Garrett is the 15th president of the Missouri Farm Bureau and an advocate for farmers and rural life and just how that benefits us all in a state like Missouri. He helps lead the Farm Bureau in its mission to identify key priorities and policies and perspectives that will help Missouri's rural areas remain vibrant and positively grow throughout the 21st century. Garrett, I would like to turn the podium over to you to introduce this next panel, and welcome, and let's get started.
Well, Chad, thank you. It is certainly a pleasure on this beautiful fall day to be with all of you from across the state to talk about an important topic, and more importantly, plant the seeds for continued improvement as we think about rural health strategies that will truly move the needle for our state. You know, it really is a pleasure. We have a distinguished panel that I will introduce here shortly, but to tell a little bit about the why. So as Chad mentioned, I'm a farmer from Appleton City, Missouri. My wife and 3 children, we raise cattle and sheep on our 3rd generation farm. We are the 5th generation, though, in our family to be involved in production agriculture. And as we truly work here on the farm, everything we do is really meant to pave the way for the next generation. And Jennifer and I talk a lot about what it takes to instill the work ethic and values in our children so that hopefully they want to be involved in agriculture as well. But for them to do that, for all of our children to come home, so to speak, we have to have thriving rural communities. And as we think about our rural communities, we have to have access to quality education. We have to have entrepreneurial opportunities. We have to have the infrastructure that paves the way for small business. And we have to have access to quality healthcare. I'm reminded of that every day on the farm. We just actually celebrated National Farm Safety Week all across the country, but agriculture is a dangerous business. It is a dangerous occupation. I'm reminded of that as my youngest was hit in the head with a rock and had to have stitches. And fortunately, we had an emergency room that was close 5 minutes from the farm in which he could get care. Actually, he's had phenomenal care through the years, both with stitches as well as having his nose glued, as well as his chin glued twice. So we are fortunate that we have access to providers right here. And honestly, for me personally, healthcare is somewhat of a family tradition. Our community continues to have access to healthcare today because of the contributions of my great aunt and uncle decades ago, who founded our community's first hospital, in which they were farmers, they were healthcare providers, and my grandfather was actually the farmhand and ambulance driver. So it truly was a family affair. Today, I carry on the family legacy by serving on our local hospital board. So the why for Farm Bureau. Missouri Farm Bureau represents 143,000 members across the state of Missouri. We have a footprint in every county. And truly, as we think about the issues that are on the minds of our members, it's not just the core issues that drive our agricultural production. It's the issues that impact our quality of life and our ability to provide for our children and our grandchildren. And right up there is access to health care. And so as I think about Farm Bureau as an organization, our grassroots policy development process that occurs every year in and year out, provides an opportunity for our members to discuss the key issues that are on their minds, and healthcare is always among them, both from health insurance and how they meet their healthcare needs to access where they can provide help, where they can find providers, or what they can do to recruit providers to their communities. So all these issues are going to be talked about today. I'd be remiss, though, if I didn't touch on what has been a challenging time for all of us coming out of the pandemic. And what we've seen in rural Missouri is a continued need for access to behavioral health services. We actually just this past summer have engaged a farmer who is on the speaking circuit telling his story about the importance of speaking up, raising your hand, and seeking help when you need it. And for so many of us that work in agriculture, we are working to tear down the stigma associated with seeking help, knowing that just the challenging environment that we've experienced as a society, but even in agriculture, means that we need to admit when it's time to seek that help. And so that's a core issue that we've worked with Extension, with Missouri Hospital Association, and others. So as we set the stage for this afternoon's discussion, I'm so excited with the esteemed panel that we have, who have records combined of helping solve issues. But more importantly, today, we're going to tee up what we're seeing right now and explore some opportunities that we have as a state. So to kick off, I'm going to go through and I will introduce each of our panelists, and then I will introduce our moderator for this afternoon and turn the program to him. So with us today, we have Steve Waldman. He serves as the inaugural campus dean for the UMKC School of Medicine, St. Joe campus. He holds joint academic appointments as a clinical professor of anesthesiology and professor of medical humanities and bioethics. Impressively, he's the author of 55 textbooks and numerous articles on specialty interventional pain management, ultrasound, and medical education. So we look forward to hearing from you, Dr. Waldman. Also associated with the University of Missouri, Kansas City School of Medicine is Kristen Kleffner. You will see Kristen brings a spark and energy to this discussion. Kristen has had experience in working with students, particularly when it comes to rural medicine, and has been associated both with the medical school at the MU campus in Columbia, as well as now UMKC. Next up is a new friend of mine, as well as Farm Bureau, Mr. Vijay Chauhan. Vijay works for BioSTL, and specifically there are two initiatives that Vijay is spending his time on. He is involved in the early adapter grower innovation community, looking at ways to move the needle in production agriculture all across this state. But he's also leading the initiative for a Center for Rural Health Innovation within BioSTL. And that's something that we within Farm Bureau are extremely excited about. Again, Vijay is one. For those who are tuning in today, you will feel the energy and the passion that he has for rural communities, and the ways that he and other leaders at BioSTL and Global STL can truly help us solve today's problems. Kathleen Quinn. Kathleen Quinn is the Associate Dean for Rural Health at the MU School of Medicine and Senior Program, also Director for Health and Safety within MU Extension and Engagement. Kathleen received her bachelor's degree in educational studies from the University of Missouri. She has a master's degree in counseling psychology and earned her doctorate in educational leadership and policy analysis. What's so important and special to me, Kathleen has spent her career focusing really on the needs of rural and underserved Missourians, and you will see that today as she helps guide us through some of the discussions. So Kathleen, thank you for participating. So Though, and then finally, I'm not sure, Brock, has Dana been able to join us? Our last panelist was
I'm
to.
not seeing
Okay.
her.
Okay. So our representative from the Missouri Hospital Association, Ms. Dana Dahl, was unable to join us. So at this time, let me introduce our esteemed moderator, Mr. Brock Slaybach, with the National Rural Health Association. There he serves as the organization's chief operating officer. 21 years of rural hospital administration, both serving on the board of the National Rural Health Association, as well as the regional policy board of the American Hospital Association. Talk about experience, Brock. You've got a master's in public health and administration from the University of Oklahoma, and you're a fellow at the American College of Healthcare Executives. So no one better equipped to help guide this discussion today. So I'm excited. I hope you all can feel it. For those tuning in, thank you so much for joining us. You'll have an opportunity to engage, but at this time, I'm going to turn the program over to Mr. Brock.
Well, thank you, Garrett, and welcome everyone to this session that we have prepared for you on rural health strategies as part of the MU Extension and Engagement Week. It is a pleasure to be able to participate in this week-long emphasis that you're having, and we hope to provide some information and overview that will be helpful to you in your work in your rural counties around the state of Missouri to further the health and welfare of the communities that you serve. Garrett, it's a pleasure to be with you in the Farm Bureau. What a wonderful organization, and your commitment to rural health is very much noted. And we thank you for your assistance today in helping with this program. Also, I want to thank everyone on the line of the panelists that are with me today, who Garrett has just introduced. All of them, I think, will provide some rich context to the understanding of rural health and how you, as extension agents and other community leaders, can be working to advance healthcare in rural communities. So just a little bit about me. As Garrett said, I am a hospital administrator by background, as I worked for over 21 years in Mississippi as a administrator of a critical access hospital. It was a hospital that ran rural health clinics in 4 different locations, and we were pretty spread out over 2 counties. So we had an interesting environment in which to serve. And so it's from that context that we'll be talking today about rural Missouri and healthcare engagement. A little bit about the NRHA, the National Rural Health Association. Our mission is to provide leadership on rural health issues. And I hope that our organization, if we can be of any service to you going forward, I welcome your input and reaching out to us if we can provide any service to you in the work that you're doing in your communities. So what is the rural landscape? Just a little bit of a background, maybe a 30,000 foot viewpoint today, kind of setting the stage for our conversation and the presentations that each of our panelists will give, and then of course the conversation that will follow. First of all, the rural landscape. One of the questions I get asked often is, how is rural defined? Well, that's a really good question. There's probably over 38 definitions, maybe more, of what rural is. And it is a very nebulous thing, because sometimes we hear people refer to the rural area. A rural area is the space between Washington, D.C. and Baltimore, where there's lots of trees. Well, of course, it's all city in between, but it is sometimes perceived, because it's not in a city, that it's rural. The way the federal government, largely the Census Bureau, defines rural is it's anything really outside of a metropolitan area. So we call it non-metro. And so rural is automatically defined as what it's not. And I think that's an interesting framework for what we do a lot in rural communities, is trying to explain our differences between what it is that rural folks will face versus those that live in urban areas. We have many challenges, but we also have a lot of assets in our rural communities. And I don't want to start the conversation today by looking at all the bad news about rural, and I'm going to get to that in just a second. But I want to start with this asset-based approach. So let's look at the state of Missouri, and we can see the map here that I've put up on for you, looking at the various sectors of the state in terms of its resources that it brings to the table in terms of rural economy. So you can see the dark green, the green colored shading is high employment agricultural areas. Many of our rural communities are extremely productive in terms of crops and livestock. Then you have accessible energy-rich hubs. These could be sources of fuel or oil, petroleum, other energy resources that are used to run our country in terms of in energy. And then we have remote recreational and cultural areas. So you can see in the southern part of the state some very obvious places where recreation and cultural areas are very well noted. And I think we need to take advantage of many of these strengths that we have to offer. And then the combination of all of this is an extremely important look at what we bring to the table in terms of our discussion. So when we look at rural, we look at some of the details about what it is and what it isn't. Rural areas make up about 80% of the land mass of the United States. And that's a lot of land, but we have roughly 17% of the United States population lives in rural communities. Now, this, of course, provides a challenge because we have lots of area with few people. And this provides or sets up the discussion for low volume or small volumes. And so providing healthcare services is unique in this environment. And it certainly is something that we have to really pay attention to in terms of the work that we do. As I mentioned, we have a lot of assets, and our rural areas provide the food and energy resources to power our nation. I want to underscore that. I want to put a special emphasis, an exclamation point after that. We have an exchange in this country between urban and rural that must not be overlooked. It was told to me once, a story of a politician, a really high-ranking member of the United States House of Representatives, got into the cab with one of our former presidents of the National Rural Health Association. Now, they got into the cab together because in Washington, D.C., when they get about a dusting of snow, they go into what they call a snow emergency over there, and they start doubling up people in cabs. And as they were going to the city from the airport, the representative was just lamenting the problem with rural health care. And he came to the point where he just said, well, you know what? It just seems to me, telling my rural friend, that if you want health care, you need to move to the city. Well, my friend very quickly responded, well, if you want to eat, then I suggest you move to the country. So I think we have an exchange going on here where we have the people living in rural communities that are powering our nation with both energy and food. And we need to have access to high quality healthcare. This is a requirement to keep these important resources available, especially in this economy now where labor is in short supply. And we're trying our best to get cruise containers off of these big vessels coming across the ocean. We don't even have enough people to get those off. We need to make sure that we have the resources in rural communities to keep people healthy and to keep them working. Historically, though, public policy has disadvantaged healthcare in rural communities. I got started in this business pretty much around 1985, 1986, having grown up in rural areas went to school, and served my career in rural healthcare institutions, I can tell you that this is not an intentional problem. No one woke up 30, 40, 50 years ago and said, how can we just simply destroy, or how can we manage to hurt rural healthcare? No one intended for any of that to happen. But over time, policies just kind of get put into the system that really creates what I call a one-size-fits-all policy-making process. So when we make a policy for the urban areas, we just assume that because rural areas are small versions of the urban facility, that it's going to work. And I think we have to be looking for tools and resources that tailor the programming that we need in rural areas to be able to make it work. So leading from that, because of these years and years of policy disadvantages, and because of all of the various factors that go into rural health, we have a fragile rural health safety net that's pre-COVID. We have vulnerable populations. And so what do I mean when I say vulnerable populations in a rural community? It basically means that we have older, poorer, and sicker individuals as compared to urban, which complicates our ability to provide services in this low volume environment. Remember, we've got all this land space, we got all this land, we've got few providers. How do we distribute services so that these vulnerable populations can have access to care? Systemic workforce shortages. This is even becoming more exacerbated as we look at as we look at the pandemic and what it's done to our country. I just heard this morning on public radio about nurses in intensive care units that are planning or thinking or contemplating about leaving the profession altogether because of the burnout that's coming from the COVID pandemic. As I mentioned, scattered populations and low access to care, and I just already talked about that, which creates limited resources for providers. If you have low volumes, and we're on a volume-based system in terms of reimbursement in this country, it's going to be it sets us up for a bad outcome in terms of coverage. Inadequate Medicare, Medicaid, and private insurance coverage. We have we have individuals in this country that are less insured as compared to urban. We have a lot of people who, for whatever reason, don't qualify for Medicaid. And so these are parts of the problems of uninsured and underinsured individuals that we have to deal with. Now, there's 12 states that haven't expanded Medicaid, and resulting in the high uninsured population. So Missouri just expanded Medicaid, and they're in the process now of implementing that program statewide. And then all of these factors have combined to create the rural provider closure crisis that we at National Rural Health Association have been paying attention to for some time. So very quickly, we've had 138 hospitals closed in rural communities. The two states with the highest number of closures is Tennessee and Texas. Other states, as you can see, had 5 to 8, which would include Missouri. And you can see Kansas, Oklahoma, Mississippi, Alabama, Georgia, and Florida are all in the same grouping of hospitals. These are some of the economics of what it goes into running a hospital. Now, why do I mention hospitals, and why is that an important part to the conversation? Well, in rural communities around the United States, rural hospitals not only serve the community in terms of emergency services, inpatient, outpatient services, but many of our rural hospitals, in fact, I would almost say all of them, operate rural health clinics or fee-for-service clinics, which provides the primary care outlets to the community. You close the hospital, you're going to essentially terminate the employment for the primary care workforce that you have in that rural area. And that is a bad, bad combination. We have 453 hospitals that are at risk for closure nationwide. Missouri shows a very high concentration of those hospitals in the state, followed and in the same company as Tennessee, Texas, and Florida. These are what we're watching, and we're certainly advocating for public policy to help these facilities to be able to cope with the difficulties that I've mentioned already. Now, uninsured adults is one metric for disparities, what we call the health disparities in rural communities. It means that the statistics in this particular metric is disparate. It's different than that in our urban community, in our urban area. And so these disparities, this is just one of many, this is one that contributes to the problem that I just mentioned. So in Missouri, you can see that about 16 to 20% of your state's rural patients, adults aged under 65, do not have health insurance. This is a very difficult problem, and it certainly contributes to the economic woes that many facilities provide. Older, poorer, and sicker, this graphic here just demonstrates that. The over 65 population, you can see, has a much higher concentration in rural than in urban. Premature death is a metric that the CDC, the Centers for Disease Control, has put forward. And this is, again, another disparity between rural and urban. Uninsured children, I mentioned the older adults, children fall into the same category as not having insurance. But when we look at the resources that are made available to us to provide these services, you'll see that access to primary care is just flipped. We have a lower number of providers in rural communities being able to serve these high need populations. Mental health is another area. You heard this morning from the those that were doing work in the opioid space, in substance use disorder. These are the areas of mental health that are so critical in rural communities that we need those resources, and we're terribly understaffed in those areas. Another area that is very problematic in rural communities is access to oral health. I don't have this on this graph, but oral health is another area. And when we look at programs of the Build Back Better program, that the president and the Congress are talking about now, where they're looking to add oral health, dental, oral, and vision services to Medicare. My question is, and one of the questions that we ask in terms of policy is, where are the people going to come from that are going to serve the newly insured people for these benefits? These are important questions as we go forward. So all of this comes together to converge to multiple pressure points. And you can see healthcare policies, the disparities I talked about, population migration, economic policies that are implemented that impact negatively rural facilities. Gosh, recruitment and retention. And we're going to have some experts from UMKC and from the University of Missouri today talk about how we get to this problem so that we'll have the numbers of people that we need to take care of our communities. And then finally, COVID-19. So COVID-19, I wanted to show the infection rates. They are going down nationally, thank goodness. Very pleased about that. But rural communities still are seeing some really high rates per 100,000. The red counties on this map demonstrate those that have high rates of transmission. You can see the rural counties, almost all of the rural counties in the state of Missouri are colored that more deeply colored red, which means that there is 100 to 500 cases per 100,000. There's one county up in Northeast Missouri that's showing a very high rate of over 500 cases per 100,000. So we need to make sure that we still pay attention to this problem as we go forward. I wanted to show you the same map in June. Green is good. You can see that we thought we had gotten the problem of the pandemic behind us back in June. Every one of us were thinking about July 4th. Remember, the president said we could all do just whatever we would normally do on July 4th. This map was showing the confidence that we had in that. But what was different, what we didn't understand, was the low rates of vaccination that were occurring nationwide. And the vaccinations to the COVID-related disease didn't penetrate as high as we thought they would. The lighter colored green on this map indicates bad. That means that there's less number of people as a percentage of the population that have been inoculated against the COVID vaccine, against the COVID-19 disease. Most all rural counties are showing, especially in the southeastern part of the state, 30% or less of the county is vaccinated. This is contributing to those red counties I showed in that graph 2 times ago, because the spread is still continuing to go in those counties with low vaccination rates. If you get access to this slide presentation, which I will make available to the organizer of this event, you can see all of the resources that we've linked to here that I would encourage you to take a look at. So, in summary, and in closing up some of my comments before we move to the panelists' presentations on various aspects of rural delivery, I covered the fact that we want to look at the asset-based approach for rural communities. What are our strengths? What are the areas that we have to capitalize on and to create the outcomes that we want in our rural communities? Healthcare is vital to rural communities for 2 reasons. One, access to care. I already talked about that. We have higher rates of people with disparate health conditions, but look at the next one, economic development. Healthcare comprises 20% of a rural economy. That's 1 out of every $5 in a rural area is contingent on the healthcare sector. When a hospital closes, when the physicians and the providers leave, we see that this depletion of the economy occurs. And keep in mind that as far as social determinants of health are concerned, economic development is a critical factor in this equation. And when you don't have a healthcare, it's very difficult to recruit new businesses and to become competitive for the economic challenges that are coming ahead. Rural communities are challenged. Public policy disadvantages, a one-size-fits-all approach that sometimes policymakers in Washington are guilty of. And we are there as an advocacy organization to say, hey, wait a minute, let's proof this policy against this notion of one-size-fits-all. And then COVID has expanded the fractures that already has pre-existed in rural areas. And we're seeing this all the time. And there's more and more data that's coming in that's showing this to be true. So the conversation today will focus on how many parts it takes to make up the whole in rural healthcare development. We're going to be taking a look today at the elements of the healthcare workforce. We're going to be looking at the economy and innovation. And we're going to be looking at how hospitals and other services in a rural community are so important to the makeup of the community. At this time, it is my pleasure to start off the conversation, to bring to the podium those 2 people who will be talking about the workforce issues from UMKC. That's Dr. Waldman and Dr. Kleffner. So Dr. Waldman, Dr. Kleffner, please take it away. And I will stop the share. There we go. You're muted, Dr. Waldman. There you go. Can you talk now?
There you go.
Okay, great. All right, Kristen?
Kristen, are you there?
Yes.
Sure, yes.
Well, take it away, guys. Thank you.
Let's see if we can get these slides pulled up quickly.
Sure.
Well, thank you all for inviting Kristen and I. We work as a great team, but I've got to give a shout out to Kathleen Quinn because Kathleen mentored Kristen. Kristen's a real expert here on building the rural workforce. So we're going to quickly work through our slides and share with you our thoughts and our experience at up in St. Joseph.
Dr. Waldman, are you able to see our slides?
I can see our slides. So go ahead, Kristen.
All right. I'd like to start off. Thank you. We had some introductions earlier, but I'll quickly just remind you who we are. Dr. Waldman is our campus dean, and he has an MD and a JD. So we have a physician and lawyer as our campus dean up here. And he is an anesthesiologist by trade, graduated from the Mayo Clinic, and is pivotal in getting our campus started. It wouldn't have happened without him. And I serve as his number two. I'm the assistant dean of our campus up here. I have a passion for students. My personal passion is working with medical students. I've done that my whole career, starting back at MU School of Medicine and now at UMKC School of Medicine. My master's degree is in counseling and PhD is in higher education administration. My very first supervisor was Dr. Kathleen Quinn, who is also on this panel, so it really has come full circle. All right, Dr. Waldwin, do you want to introduce this video?
Sure. So it seemed to me the best way to tell the story is start at the happy ending, which is our amazing new rural campus. We're located up in St. Joseph, Missouri, and affiliated with the University of Missouri Kansas City School of Medicine. So we're going to just share a brief 2-minute video. Pictures worth 1,000 words. So Kristen, can you?
Yep, I've got it going.
Hear it, but don't see it.
Uh-oh. Can't see it?
Can't see it.
It may be in another screen, Kristen. You may need to share another screen on your desktop.
Let me see. Sorry about this. Let me pop out just for a second. Well, why don't I work on this and Dr. Waldman, you go on with the slides. How's that?
You're
Kristen, in the chat, it says, click optimize video and share sound.
Okay, let me see. Optimize video for clip and share sound. Got it. Okay, let's try this again.
Oh, Kristen, you have to stop your PowerPoint and stop your PowerPoint share and reshare your internet browser. It'll be worth it.
Okay.
This is Ryan and Kristen. I dumped all the IT off onto her.
Okay.
Here we go.
Now reshare the screen to the YouTube screen.
Okay, got it.
I'm sorry, Kristen.
That's all right, we'll get it.
Go
Thank
back
you for
to
your patience.
Take it back to the beginning.
Here we go.
you guys, I believe, have been in lab today on, correct? Going over the different models.
Thanks, Kristen.
Yes, I'm going to get us back to our PowerPoint now. Bear with me. Dr. Waldman, do you want to just get started while I pull this up?
Sure.
Okay.
So as you can see, we the end of the story is a beautiful campus with absolutely amazing students. And what's exciting about what we've accomplished up in St. Joe is we have students that have selected the idea of being learning, living, and hopefully practicing in a rural campus. So in a rural community in Northwest or throughout Missouri. So this is a departure from where we were at. So the UMKC School of Medicine is 50 years old, and we've been talking about our mission and vision, which is to train physicians to practice in Missouri. And we've worked really, really, really hard on that. It started to become pretty apparent that we were doing a good job, but not a great job. And so we wanted to come up with a way that might really, really, really double down and focus on rural healthcare. So, Kristen, are we going back to the slides? Do you want me to? I can talk for 5-6 hours.
Yes, the slides are back up now.
I'm not seeing them.
Kristen, I'm not seeing the slides. I'm not.
Oh, no. Okay, let me do this again.
You guys realize I can never go back to the St. Joseph campus. Kristen is going to kill me.
I can get there. Hold on just a second.
So we spent a lot of energy trying to, there we go. That's about where we are, Kristen.
Right here.
Anyway, as with most things in higher education, and I guess really with most things in life, it's really the money that drives the conversation. And Brock did a great job of summarizing the challenge of the healthcare manpower shortage across rural Missouri. And it's not kind of just bad across rural Missouri. When we look at how we stack up against other states, it's kind of a problem. We kind of slid along for a while, and then somebody woke up down in Jeff City and says, "Hey, what are we spending all this money for?" And that really was the inflection point to start the conversation. So funding, that's what it's all about. So as with many things in higher education, we spent a lot of time talking about it, thinking about it, but really hope that we could continue to do the same thing and somehow something would change.
So School of Medicine decided we were going to find a way to invest in this new campus, and that's exactly what they did with the help of some HRSA grant funding. Which came into play with the we have no money, and suddenly we had funding, which really helped us get things moving in motion quickly. So with no funding, we finally admitted that the status quo wasn't working, and we needed to take immediate action or things weren't going to work well for our campus.
So I would like to tell you that this was easy. Kristen said, "Oh, don't show these slides. They're too, I guess, negative." But we've got a couple hundred people here on this Zoom call that are interested in improving the rural healthcare workforce. And I have to tell you that unless you move outside your comfort zone, unless you take bold action, and unless you really drill down on the problem, this can't be something that can be done from Kansas City or St. Louis. You've got to move outside that comfort zone. It was really painful. It was really hard, but we got it done. And it was really a cataclysmic shift. But again, you've seen the happy ending. So I hope that doesn't make this sound too negative. Just recognize that we didn't get in this situation overnight. So this campus represented the first increase in UMKC School of Medicine class size in 50 years. That's a big deal in and of itself. More doctors equals more care, more physician assistants, anesthesia assistants, nursing means more healthcare. And by taking this outside Kansas City and putting our students, our faculty, our staff in a rural community to live there, love there, learn there, and then add graduate medical education so they can do their post-medical school training there, I think we've got a real formula for success. So the next challenge, once we decided we were going to move out of Kansas City, was find a place to move. Brock really laid it out. We could really flip through these last couple of slides quickly. Hospital closures and just the specific needs that Kristen will outline, that you need to train healthcare professionals. There's just not a lot of options around the state.
So when we were searching for our needle in a haystack, some of the things that we were considering are listed here. Value in primary care, patient-centered focus, importance of quality and patient safety. There has to be a clinical volume. That's important to make sure that we're meeting our accreditation standards as a medical school, and sometimes that's difficult in a more rural setting. And so we needed to find our needle in a haystack, and that's what we have done. But before we found it, we did look at an awful lot of haystacks. Dr. Waldman, do you want to speak a little bit about that?
Well, I think that matching the educational imperative and the accreditation imperative is the thing that drive medical education accreditation with the available clinical sites was a real challenge. And a small critical access hospital, while integral and important to a portion of a medical student's training, can't provide the scope or breadth of training that the students really need. So we got lucky. We got really lucky. So we're looking all over, and it was a hard. This is a difficult conversation when you're asking a hospital administrator, "Hey, we'd like to bring 80, 100 students up here, and we've got all these rules and regulations, and they've got to have a safe call room." I mean, I could go on for an hour. Some hospital administrator says, "Sounds like a great idea, but we're not equipped to handle it." And we, as I said, got very, very, very lucky. So we found Mosaic Life Care. I had actually practiced there in my private practice days back when it was Heartland Hospital. Boy, did it change. I was really quite surprised at our first meeting.
And so what we've found at Mosaic Life Care is it really did fit that bill of being a bit of our unicorn, that it had the values that matched ours, the leadership, the technology, and the motivation, of course, to meet the needs of Northwest Missouri and the state of Missouri in terms of rural healthcare. All right, so I'm going to switch to one more video, and I know how to do it all this time, so bear with me. Dr. Waldman, do you want to add in a few points while I get this going?
Sure, and I'm sorry, Kristen, don't be mad at me.
No, it's fine.
We planned to do this together in the same room, in the same office, and I got dragged down to our Kansas City campus to share some exciting news about additional grants that we've been awarded for rural healthcare. We found out today that we were, the St. Joseph campus was awarded $2.2 million from HRSA for rural behavioral health. So we're going to be bigger, better, and greater.
All right, I'm going to play this video. Let me know if you can't see it.
For over 50 years, this is where you'd find the UMKC School of Medicine, preparing physicians of the future in the heart of Kansas City, Missouri. And now you'll find it here, too, in St. Joseph. That's right, a full 4-year School of Medicine has just been launched at the Mosaic Life Care Medical Center, bringing the dream of becoming a doctor closer than you think. Why St. Joseph? Well, the fact is that there is a physician shortage in America, including rural Missouri. So, a campus has been designed for students to live and learn where they are needed most. A city in a beautiful countryside, high tech that transforms, and high touch that transcends. Mosaic Life Care is a nationally recognized state-of-the-art medical center that is part of the Mayo Clinic Care Network. So you know that you're getting trained by the best and the brightest. Each student is linked to the UMKC School of Medicine Health Sciences District and the Mayo Clinic Care Network, even right here in your own individual learning area. Our classrooms and small group learning spaces allow you to interact with your faculty and classmates, whether the lecture is presented in person right here or in a live remote learning format from the UMKC School of Medicine Health Sciences campus in Kansas City, from the Mayo Clinic Care Network, or from anywhere in the world. This is the Exploratorium. It's one of our learning studios for basic sciences and clinical skills, hands-on training, and so much more. You can clearly envision yourself as a practicing physician and know that you're getting one step closer. Since we are located right inside Mosaic Life Care, one of the busiest tertiary care hospitals in the state, you'll get all of your clinical training right here. But we're part of the Mosaic Life Care health system with 3 hospitals and over 42 outpatient locations where you can learn. Mosaic is one of the largest rural healthcare networks in the nation. You'll also have the opportunity to do clinical and research electives across the country, as well as with our international partner institutions across the globe. In addition to the academics, I think our students are attracted to our aesthetic, and how welcoming Mosaic is, and how everything you need is right here. And finally, no look at the School of Medicine St. Joseph is complete without mentioning the docent teams. A docent is an experienced faculty physician who leads a group of 10 students who learn doctoring in a hands-on active learning community. These mentors help guide your personal and professional development as you develop the attitudes, beliefs, competencies, habits, and professionalism needed to become the best physician you can be. And with your docent, you'll start seeing actual patients in your first week of medical school. So, the UMKC School of Medicine is not just in KC. If you have a dream of becoming a physician, this might just be the place for you. Right here in St. Joseph, Missouri. Maybe the dream is closer than you think. Mosaic is one of the largest rural healthcare networks in the nation.
Kristen, you did it. Well, thanks very much for your time. We'll be happy to answer any questions. And again, a thanks to Kathleen Quinn, who really was way ahead of the game on this and provided a lot of mentoring and inspiration to help get us up and running.
Thank you very much, Dr. Waldman and Dr. Kleffner. Terrific presentations. I want to turn now the segue to Dr. Kathleen Quinn, who will take us through the other elements of the workforce work that she does, as well as talk a little bit about the role of extension in advancing healthcare and other topics that are important to her.
And Megan, do you want me to try to share my slides? I can try.
Kathleen, they can run them here for you.
Okay. So I'm going to be talking about 2 programs today. One is our workforce development program that we started in 1995, actually. It's the Rural Track Pipeline Program. And then following that, I'm going to talk a little bit about a very new program called Community Health Engagement and Outreach. Oh, I won't be able to see them. Okay, good to know. Okay, so if we're on the pipeline slide, you can see our pipeline on the title slide, and I'm not going to go into detail of all of the programs because we don't have enough time, but we do start with the right students on the bottom left, and those are students not only from rural communities, but the literature tells us that if we recruit students from rural communities, they're more likely to end up in rural communities. And then I'm going to talk a little bit about the other programs as students traverse through School of Medicine and a little bit later. Next slide, please. So just to kind of go along with what Brock was saying, I'm not going to go through this slide either, but I did want you to see that we do have many fewer primary care physicians in rural Missouri than we do in urban Missouri. And the whole point of our Rural Track Pipeline program is to increase the number of physicians practicing in areas of need. Next slide, please. So as Brock mentioned, I believe he said that 17% of people in the United States live in rural communities, but in Missouri, it's actually 37%. So we have a higher percentage of people living in rural communities. 90% of our counties face a physician shortage, as Brock pointed out. But we have 18% of physicians practicing in rural communities. And that's better than the national average. National average, only 10% of physicians practice in rural communities. Program beginnings, if that's the slide that you all see. This is a photo of Lester R. Bryant. He was actually a cardiothoracic surgeon, but he was from a rural community, and he was our dean around the turn of the century. And he is the one that started our program. And I am forever thankful to him because he understood the need for rural physicians. So the Rural Track Pipeline program encompasses 4 programs. We do pre-admit students from rural communities. We work with them for 2 years prior to them matriculating to the School of Medicine to help prepare them for medical school, not only academically, but we bring them on campus so they're familiar with the physical environment of our school, and they also meet our faculty, and they have friends when they matriculate here. So that's always a good thing. You have someone that you know when you start medical school. Once they come to medical school, we have 3 rural programs that they take part in while they're here: the summer community program, the rural track program, and the rural elective program. Next slide, please, the one that shows the Missouri map. These are the sites where we train our students. And you will see that St. Joe is one of our sites. It was actually one of our first sites in 1995. So our students are now with the UMKC students in St. Joseph, and we are anxious to have them all work together for the same goal. Our students starting next year will actually be up there for the entire year. And that's the same as in Sedalia. Other sites, they just go for half of their 3rd year, and they do the other half of their training at the Academic Medical Center. The participating hospitals, next slide. We cannot do this program without our partnering hospitals around the state, and we're very, very grateful. We don't pay our physician teachers. They do it because they understand the need to recruit their partner or their replacement. Next slide. Our students, we found out that our students weren't really integrating into the community. They were going from the grocery store to the hospital to their house, which we do provide housing, and they really wanted to get more involved in the community. So about 15 years ago, we started a community integration project. And so the students address a need while they're in the community so they can give back to their host community. It also integrates them into the community. So they not only know the medical community, but they know about the community at large, which helps them when they go back to practice there. And they understand referrals for their patients, whether it's for food, clothing, shelter, etc. So it's been a really great program. Next slide. I wanted to show this slide because it shows the outcomes. If you just look at the right side of the graph, the left side is where our students go to residency. But if you look at the right side of the graph, you can see that 59.4% of our students practice in rural communities. 49% of those are in Missouri. So it's much, much higher rate than the 18% that we talked about at the beginning that practice in Missouri. It's a small number of students, but it is making a difference. And many of our graduates are practicing in St. Joe and are teaching both MU students and UMKC students. So that's extremely exciting and satisfying. And they loved being in the rural program, and so they're happy to teach and give back. Next slide. The Clinical Rural Immersion Program is a program we started about 5 years ago. And this is an interprofessional program because, like others have said, you want to also recruit nurses and pharmacists. And so this program brings all of those professions together. And for 2 weeks in the summertime, and we rotate different rural communities. This coming summer, it's going to be in West Plains. Last year, it was in Sedalia. And they go for 2 weeks and they learn about each other's professions. They work together, but then they also work separately. And again, they learn about the community and what they will be responsible for, not only as a citizen in the medical community, but the community at large. So the next slide, I just wanted to talk a little bit about how Extension can help. Extension can help with this program by identifying high school youth, and actually with, for example, 4-H, even students younger than high school, because a lot of times it takes a long time to prepare students for health professions. I'm on the next slide after this, please. And on the How Extension Can Help slide. So if you know of students that are interested in health professions, we can refer them to the regional AHEC or the MU School of Medicine. Welcome healthcare students that are in your community. We try to tell Extension about all the students that are in their community. So, and I have had a lot of help from Extension professionals, help them integrate into the community, help them find community integration projects. It's been a great partnership. If you just give the students a community tour so they know whether it's getting involved with 4-H or whether it's figuring out where they can get their tire fixed, it is all extremely helpful. Involve the students in your area in local events, volunteer to participate in clinical rural immersion, and highlight your expertise level with Extension, and then also welcome new rural physicians and healthcare professionals to your region. So the next program I want to talk about is community health engagement and outreach. This is a program that we started about 2 years ago through Extension, and we work to promote health, safe and thriving communities where health is a shared value. And our mission is to achieve optimal health and well-being for every Missourian at every stage of life. And our work focuses on prevention. And you might have seen Chiquita Cheney this morning talking about, and others talking about, opioid use disorder. And we work with youth and adults. So community health engagement and so in order to positively impact health and well-being at an individual, community, and state level, CHEO is what we call community health and engagement and outreach work. We focus on prevention and health promotion. And this slide shows some of the initiatives that we're currently working on, which will hopefully give you a better idea of the impactful work that is taking place across the state. And so you heard about this morning about recovery-friendly workplace, and Chiquita also talked a little bit about Prosper. We are doing a lot of work with immunization training and education. Many of you have probably seen our monthly COVID and flu vaccine live streams. And we're also doing a lot of work in Southwest Missouri on diabetes support and prevention. Next slide. So it's important that our work is relevant and addresses challenges faced by people and communities across the state. And so we believe it's imperative to regularly hear from all of you that are working at the community level. You can expect to receive a periodic survey from CHEO that we hope you will take the time to complete. We have a feedback loop that is important. That's an important tool for ensuring that you have the resources, support, and tools that you need to respond to the challenges your community may be facing in regards to overall health and well-being. So if there's ways that we can be helpful, please reach out. And at any time we will time to discuss our ideas and explore opportunities for collaboration. We strive to bring a sense of curiosity to our work and explore possibilities that will improve the health and well-being across the state. And that's all I have today. Thank you.
Well, thank you, Kathleen, and thank you for that great presentation of the work that you're doing over on the Columbia campus. And now, without further delay, I'd like to welcome Vijay Chauhan to the podium and share a few thoughts with us before we engage in a few minutes of Q&A.
Great. Thank you so much, Brock. It's a real pleasure to be speaking to the community from the Extension family that is at this webinar. I want to begin by thanking Marshall, Allison, and Chad for welcoming BioSTL into your family. I want to thank Garrett Hawkins for welcoming us into the Missouri Farm Bureau family. And then, of course, Steve, we feel like we are home in St. Joe through your wonderful hospitality over the several calls we've had. But my newest family that I feel we are part of now is Brock's family at the National Rural Health Association. So let me tell you about who we are and then why we are part of these wonderful families. So my name is Vijay Chauhan. I work for an organization in St. Louis called BioSTL. We were created 20 years ago to build an innovation economy for St. Louis. 20 years ago, we had a lot of innovation, but we had no ability to convert that innovation to entrepreneurial activity, to create high growth companies and the economic outcomes that come from that. And so we have been on a mission to transform the economy of our region through innovation, becoming more globally connected, and bridging urban-rural communities. This has been sort of our mission from day one. And so we do several things, but the ones that are most relevant is first, we create companies from ideas and innovations in our region. We've created 95 companies. We've put $35 million into these companies and helped these companies raise $1.9 billion. That money came from, 90% of that money came from outside our region. So we became very good at recruiting capital from around the world to our companies. 6 years ago, in addition to creating our own companies, we said, can we recruit top innovation from around the world that is coming to the US, but does not think about the Midwest as a place to land? They all want to go to Boston, Silicon Valley. And we said, how can we become a magnet for that best innovation to come to our region? And so that is the work that we do through Global STL. And we have now built a significant engine for finding the best innovation in agriculture, health, and food. And having found all these innovators to come to our region now, we have built a very big solution toolbox for things that we can do to solve for major problems. And we did that by bringing all the major healthcare organizations out of their silos and put them on a common platform and said, can we work together as a single family and build ourselves into a big magnet for these innovations? So to give you an example, if you add up all the healthcare organizations that are in St. Louis alone, the revenues that flow through these organizations are $265 billion. That's about 7% of US healthcare spending. If you tell somebody around the world, come to a place where you can get access to 7 or 8% of US healthcare, they are ready to get on a plane and come to us. And we actually have more buying power than Boston, Silicon Valley, Chicago, Nashville, Cleveland, Philadelphia. And so our ability to do that was very good in bringing that buying power to our region. So we have now access to cutting edge innovation. And so we asked ourselves 3 years ago, how can we help rural communities engage with this innovation to solve for the problems that they have? So we started with agriculture, where we asked ourselves, if this innovation is finally going to show up on the farm, why don't we sit down and talk to farmers directly and ask them, what is it that you're looking for? And how can we then go out into the world and get you the best innovation? That's the program that we call EGIC, Early Adopter Grower Innovation Community. I had the good fortune of meeting with Marshall about 2 years ago in March, April of 2019. And once he understood who we are and what we are doing, he brought us into the College of Agriculture at MU. We met with Rob Collenbach and his team, and we started to work with them in grower-centric innovation to the farm. We then said, let's do the same thing in healthcare. Can we sit down with rural communities and understand what kind of healthcare would really bring value to those rural communities? And again, in doing that, we connected with the extension team, and they have been our trusted partners in bringing us into rural communities. As we've been talking and listening to our rural communities, we began to realize there are 4 major challenges that rural communities face. And we've been discussing all of that, and Brock's presentation did a fantastic job of setting the context for these 4 problems. First, it's healthcare access and affordability. We all know what that problem is, but I'm going to come back and tell you, we at BioSTL, we live in solution land. When we look at these problems, we are saying, what solutions can we deploy in the here and now that can make a difference in that area? And I'll come back and talk about 2 specific ideas that are actually moving forward in Missouri. The second one is around healthcare workforce capacity. And that's what Kathleen's presentation, that's what Steve's presentation, and Kristen's was all about. How do we bring rural workforce back into rural communities? We know that the future of healthcare in rural communities will not be the model that we have today. The model of today is where the person needs to go to the care, and that care is getting further and further away. 30, 40 miles you drive for a 15-minute appointment with a doctor. You're supposed to do that every week for 10 weeks if you're in some kind of a physiotherapy program. Very hard for people to do that. So we know that the model of the future is going to be some good combination of bringing the care to the person on the person's terms. So we generally think about that solution through the lens of telehealth. And yes, telehealth will be a very powerful platform for bringing the care to the person. But we all know for that to happen, you need high-speed broadband. So the third area we are solving for is in making digitally connected economies a reality in rural communities. And we heard about broadband through our conversation with our farming producing partners, as well as our healthcare partners. And so that's the third thing we are focusing on. And then the fourth one, which was brought up in each of the presentations before, is the social and economic drivers of health. It really is surprising that if you want to improve the health and longevity of people, only 20% of that can be impacted by what happens between you and your doctor. The remaining 80% has a lot to do with your access to transportation, jobs, access to fresh, healthy food, access to healthcare. So we are focusing on addressing the loneliness and isolation issues that are facing rural communities, the economic impact of a shrinking economy. So we want to bring digital economy jobs to rural communities. And these digital economy jobs are going to attract the young people to come back home. But you got to have high-speed broadband for them to see a life that they can live in the on the farm. And so when we think about these 4 things, that's what we are advancing in partnership with Extension, with the Farm Bureau, with Steve and Kristen's team in St. Joe, Missouri. And so now let me give you a couple of examples. So problem number 1, access and affordability. So we know that there are many folks who live so far away from their healthcare that the only way they actually access healthcare is through the emergency room. Because that's when things get really, really bad and they have to do something, they're desperate, and now they're going and seeking that care. So we brought a company from UK called Babylon Health that had built the ability to have primary care doctor to every person on earth in the palm of your hand. They started in UK, they went into the country of Rwanda, and 4 million people in Rwanda now have 24/7 access to primary care, even better than care you can get here in St. Louis. That company was brought to St. Louis through our work. They met with Centene. And the first deployment of their highly accessible, affordable primary care service was deployed in Southeast Missouri in 10 counties. It started in October last year. And here is what the problem that they're solving. Centene gave them 18,000 people that do not have any relationship with a primary care doctor, a physiotherapist, a diabetes. The only relationship they have is the emergency room. And every time they go to an emergency room, it's $5,000 to $10,000 expenses. This company said, give us that population, and our job will be to make them receive the best 24/7 care that they deserve. And that company now has taken the next step, which is they went to Centene and said, we will take a fixed price at-risk contract. Give us a certain amount of money, and that's all we will get from you. And our job is to keep these people healthy. This community now has been contacted and reached by this company. And we have now 18,000 people who have 24/7 access to primary care. If they find themselves needing to go to a doctor and they don't have transportation, this company organizes the transportation at no cost. They don't have access to food, they organize access to food. They don't have access to behavioral health, and that's the big challenge. They're connected to a behavioral health person. All of this is done 24/7, and the person is receiving the care on their terms. And the reduction in emergency use is starting to take hold. But most importantly, 98% of the people who have received this care are so happy with the care that they're receiving, and they will not let any other model become their first point of contact. So the relationship and trust they've built with this platform. And the beautiful thing is this company realized they don't know Southeast Missouri. They are not from here. So they ended up hiring local people, and they told us, tell us, how do we serve your community? How do we engage? How do we communicate? And so you see a Southeast Missouri-led team bringing care to this community. You are going to see this in a program I'm going to tell you about here in a second. We have a rural health symposium that's coming up on the 2nd of November, and you're going to see an example of it. I'll give you another example of a solution that we have identified. So
BJ, you've got about 2 minutes, and then we'll need to start wrapping up if that's okay. Sorry about that.
Great, no problem, Brock. If you live in rural Missouri, if you're an employee or an employer, every year your healthcare spending goes up significantly, and you're not able to afford the healthcare, so you end up creating higher and higher deductible plans. And if you've got a $3,000, $4,000, $5,000 health deductible plan, even if your doctor is 2 minutes away, because you're afraid of taking on the risk of the first $5,000, $2,000, you're not going to access that care. So we have a model of bringing zero deductible health insurance to employees, 20 to 30% savings for the employers, and increased revenue for the local hospitals. Think about that model where everybody comes out ahead. So I want to just share that very quickly and end with a couple of things. One, we're going to have a rural health symposium where you're going to hear these kinds of ideas, solutions being brought to rural communities. And we're going to be launching for the Center for Rural Health Innovation. We really hope you can come because you're going to see really powerful innovations where we are bringing the care to your home. And if you want to sign up for that symposium, then here is how you can do that. Please reach out to my colleagues, Katie Dowd or Nicole, shoot them an email saying, I'd like to attend. You can attend it virtually or in person. So I'm just going to stop here in the interest of time. Thank you so much for allowing us to tell you about our work with rural Missouri.
Thank you, BJ. That was an excellent overview of the work that you're involved in. And I have to say that going forward, it's been long conviction of mine that innovation is going to be the only way that we can spin ourselves out of the orbit that we've been in for 5 decades or more in rural health. And so I'm really excited to see the work that you're doing to help make that happen. We did have a question that came in through the chat before I turn it back over to our hosts. Dr. Waldman, does the program there at Mosaic Life Center, the School of Medicine there at St. Joseph, does this program extend to Mosaic's sister hospital in Maryville?
I'll go ahead and jump
Kristen,
in if that's okay. Yeah,
please.
sure. We don't have, our medical school hasn't expanded there. So there's not students who are on that campus in Maryville for 4 years. Certainly there may be some clinical opportunities for our students to head over to Maryville as a partner location at Mosaic. But it is not, there is not a medical school at that Mosaic site in Maryville at this time.
Thank you very much for answering that question. I want to extend my thanks to all of the panelists here today for their terrific information and being able to help us all understand rural health a little bit better. At this time, I would like to turn the program back over to Garrett, who will summarize our points today and then conclude our presentation from the MU Extension.
Well, thank you, Brock. I've been taking copious notes, and I know for those who are tuning in, you'll be able to access presentations post engagement week. So I want to thank our colleagues at MU Extension, starting with Marshall Stewart and Allison and others who are making this possible, and Chad for helping kick off this session. I know for me, as I travel the state, it's important to give not only Farm Bureau members, but all rural Missourians hope. And what I heard today is there is hope. And especially for those of you who are the face of extension in our rural communities, you're in a great position as you hear questions from your fellow community patrons. You're in the position to be the face and the voice in articulating the hope of what I heard today, knowing that there is collaboration happening all across the state, that we have folks who are devoted to innovation and helping drive some key issues in discussion and helping find solutions, but ultimately giving hope to those who are on the front lines. And I know for us, as the second smallest critical access hospital in the state, giving our team on the ground hope that there are people who are listening to the issues that they face as they try to provide health care day in and day out for the citizens of this state. So again, thank you to our panelists for the ideas that you have presented today. Thank you for the takeaways that my wheels are turning now as to how we continue this discussion. And VJ, thank you for mentioning your Rural Health Symposium that will be coming up in November. So if you all are interested, this is yet another way to engage in this conversation and to carry it forward. So thank you again. And Chad, I will turn it to you.
Well, a sincere thank you to Garrett, Brock, Steve, Kristen, VJ, and Kathleen for a fascinating presentation and a discussion around the health disparities that we see in rural Missouri. What a panel of true experts. Some of these key takeaways were just, how we have a workforce disparity. We have hospital closures. We have just a general idea that our rural population is not comfortable reaching out and asking for help. It's a real challenge to move the needle in a forward direction. So thank you for all that you're doing on the panel. Thank you so much for all the effort. But also, Garrett, to your point, also hopeful. The idea that we do have innovation around precision health care and next gen approaches. It just really shines a little bit of light that there is hope, and so I'm looking very forward to seeing what we do and what this meaningful communication with rural populations may reveal as we explore the reciprocity between the UM system and rural Missouri. So many thanks to the panel this afternoon, and many thanks to everyone today for an informative day and an inspiring day, and to our sponsors, Hush Blackwell and the Missouri Hospital Association, and to our partners, the Missouri Foundation for Health, MU Healthcare, MU NextGen, and Precision Health, and the Novak Leadership Institute. And we'll see you all back, hopefully tomorrow morning, bright and early at 8:30, as we kick off another exciting day with information about health challenges caused or worsened by natural disasters. We'll highlight the grand opening of the Roy Blunt NextGen Precision Health Building, and the future of research and modalities that will help improve individual and community health outcomes for generations to come. And in the afternoon, we'll explore a vision of what it will actually take to achieve health equity for all communities in the state for the next decade. So until then, so long and have a great rest of your day.